Hello everyone, and welcome to part 3 of our webinar series on HIV genetic sequencing. The title of today's webinar is Understanding Molecular HIV Surveillance, Public Health and Human Rights Implications. So as stated, this is the third webinar in a series, and in this webinar today, we are focusing back in on the public health sphere of this technology known as HIV genetic sequencing, and in this case, in the public health context, molecular HIV surveillance. The previous webinar was focused more on the research realm and how genetic sequencing of HIV is being used in clinical research studies of issues such as novel HIV therapeutics, HIV cure research, HIV prevention research. But today we're looking more at the public health sphere, and there of course is some overlap between research and public health, which is why this webinar is important to us. So I'm Brian Manalga from the Legacy Project. Legacy is an organization focusing on building trust and collaboration between HIV research institutions and the communities bearing the greatest burden of HIV in the United States. So that's why we've collaborated with some other organizations to put on this webinar series. I just wanted to also point out that today's webinar and this series overall is a lot about dialogue. So we're bringing together folks from lots of different backgrounds, from public health, from health departments, people living with HIV, various communities that are vulnerable to HIV. So it's important to note that through dialogue, there may be disagreement, and disagreement, of course, can be respectful and productive. And in fact, often conflict and disagreement is the only way that change happens. So it's important for us to recognize that, and also, of course, to recognize power dynamics within this conversation when we have dialogue. We started the series with centering people living with HIV from various populations that are marginalized and disenfranchised. So it's important to keep those power dynamics in mind as well as we engage in this dialogue. So just a couple housekeeping items. This webinar is being recorded, and you can find the recording and the slides on our Facebook page. And there it is. You can find us at Hank Legacy Project on Facebook. I'll also put that link into the chat box. I see some folks might be having some issues with sound, and it looks like most people are dialed in to the audio, so I'll put a note into the chat box as well to help people dial in to the phone. So also there will be a webinar survey following this webinar, so please fill that out. That will help us. And lastly, you can use the chat box in the lower left-hand corner of your screen. So feel free to participate, ask questions, make comments as the speakers will be presenting their talks today. Again, this is a 4-part webinar series. And we've done, part 1 was back in March, part 2 was last week on research, today is on public health, molecular HIV surveillance, and we hope that you'll all join us as well next month on May 15th for the final part in this webinar series, which will be more of a discussion. Again, this is a collaborative webinar series among these organizations: the U.S. People Living with HIV Caucus, Positive Women's Network USA, the Legacy Project with the Office of HIV/AIDS Network Coordination, the Sero Project, Thrive SS, the Reunion Project, the International Community of Women Living with HIV North America, and Positively Trans. And so with that, it is my great honor to introduce our 2 presenters today. First up will be Eugene McCray from the Division of HIV/AIDS Prevention at the Centers for Disease Control and Prevention, who will be followed by Naina Khanna, Director of the Positive Women's Network USA. So with that, I will hand it over to Eugene.
Good afternoon, and thank you, Brian, for that introduction. So we're at an exciting time in HIV prevention with better testing, treatment, and prevention options than ever. However, we must optimize delivery of these interventions to maximize population health. Today, I want to talk with you about an approach that aims to do exactly that: cluster detection and response. Particularly, I want to talk about how CDC and health departments use molecular HIV data. Okay. So by the end of this talk, I hope to have made the case that cluster detection and response can bring the nations closer to ending the HIV epidemic. I will start by outlining CDC's domestic HIV strategic priorities. Then I'll outline how public health surveillance work and how we currently use the data. And then I'll wrap up by providing an example of cluster detection and response activities in the real world. So as many of you are aware, the President included in his FY 2020 budget a new initiative to reduce HIV infections in the United States by 75% in 5 years and by 90% in 2030. Over the past few years, our domestic HIV program has closely mirrored the pillars of the initiative. Our director, Dr. Robert Redfield, has been working very hard to enlist support for the initiative and strongly support comprehensive and culturally appropriate solutions to ending HIV in America and reducing stigma. This initiative will support CDC's existing programs by working to bring HIV testing to everyone and diagnose people as early as possible. It will promote rapid care and treatment as soon as possible after a person is diagnosed. We will protect people at risk for HIV with proven prevention interventions. We want to respond rapidly to growing clusters in a responsible manner, and we want to support building a multidisciplinary workforce based on local gaps and needs. So today I'll focus on the respond pillar, what it means and how it's being implemented. I'd like to make the point that although this work is represented in a separate pillar on this current graph, this work is really not isolated from the other pillars. It's an important way to use data to inform and help prioritize all the prevention work that's being conducted under the other 3 pillars of the initiative. People's health is on the line, and to achieve our prevention goals, we have a responsibility to do everything in our power to use all the tools available to us. So public health monitoring is important for identifying disease trends and can be useful in detecting specific populations that are experiencing outbreaks. For example, public health data can help find foodborne outbreaks and keep food supplies safe. There are also public health monitoring systems for many of the reportable diseases or conditions at CDC, including cancer, certain injuries, sexually transmitted diseases, hepatitis, and tuberculosis. It's also important for helping people to get in care and stay well. For example, when public health identifies a community with increases in tuberculosis, it can help to get testing and treatment to the people who need it most. Overall, public health surveillance helps us to target limited resources to the people and areas that need them most. For example, public health data help to identify states with high rates of drug overdoses. Those states can then work to prevent overdose and treat opioid use disorders. So we are all acutely aware that HIV is highly stigmatized, and people with HIV may face serious social and personal risk in some communities, including criminalization, loss of employment, loss of health insurance, and many others. There's also concerns about data security and confidentiality and uses of data for non-public health purposes. And these issues were central to the debate that occurred around name-based reporting of HIV diagnosis to the health department throughout the 1990s. So in response to these concerns, CDC and health department, along with input from community, implemented unprecedented strict policies and procedures to ensure data security and confidentiality. The use of these data was severely restricted for only public health purposes. So let's talk a bit about how we use HIV public health data. As a result of strict data use policies, initial use of public health data focused on describing populations by risk categories, age group, race, ethnicity, geography, year of diagnosis, and several other factors. So imagine that each dot in this slide represents a person with newly diagnosed HIV infection. Public health data help us to better understand who is being affected by HIV. For instance, how old were they when they were diagnosed? That is, what is the age of diagnosis? Or what's their race ethnicity? This is how we can learn that some groups are disproportionately affected by HIV. This information can also help us to understand what types of prevention interventions are needed for whom and where. We also know that public health data need to evolve over time. For example, we've been working to collect improved data on gender identity. This information allows us to better determine and understand the needs of transgender population. Additionally, with more prevention options, we have begun using public health data in new ways. So, for example, with data to care approaches, health department can use public health data and other data to identify people who appear not to be receiving HIV care and can offer additional support. We can also use public health data to identify increases in HIV transmission in specific communities or populations. For example, we might find that a particular community which only has a few new diagnoses in a typical year all of a sudden have a lot more than one would expect. This could signal an outbreak, perhaps like the outbreak that we saw that occurred in Indiana, Scott County, Indiana in 2015. So we also have a new tool for identifying a situation where there is increased, we also now have a tool for identifying a situation where there is increased transmission. We can use lab data to identify groups of infection that are very similar, much like public health does when looking at outbreaks of tuberculosis or foodborne illness. A cluster of HIV or health conditions refers to a group of people who are related spatially, molecularly, or epidemiologically to the condition. There are several ways clusters are detected. For our purposes, we are mainly talking about molecular HIV clusters. This means a group of people that have similar strains of HIV. So, for example, here you can see several clusters or group of people with similar strains of HIV. Their similarities suggest that they are all part of a common network and that HIV likely spread quickly throughout this network. So let's zoom in on one of these networks. If focusing extra attention on these networks can help us to see what resources are needed and target our outreach effort. For instance, by contacting partners or people in the network, we can work to find others in the network who might not have known they were HIV or that they had HIV, or help, sorry, I moved a little bit too fast, or help people who are at high risk of acquiring HIV to avoid getting it. We can also work to understand what barriers may exist and identify ways to help reduce these barriers so that people can get the prevention and care they need. I just showed you that we can use laboratory data to identify networks in which HIV is spreading rapidly. So what are these lab data? Well, as part of HIV care, healthcare provider order tests to learn which treatment will work best for a person's HIV strain. This is called drug resistance testing, and it involves determining the genetic sequence of the virus, not the person. We sometimes call this molecular data. This information helps the provider to make treatment choices, and you might have heard people refer to the collection of this information by public health as molecular surveillance. Drug resistance testing is also important for monitoring drug resistance in the population. If many people develop resistance to commonly used drugs, it can make HIV more difficult to treat and affect treatment options that are available in the community. Health departments can also use this information to see if there are similarities between these viral sequences. HIV changes over time, and it changes a little bit differently in each person. So most people, for most people, HIV looks differently than, most people HIV looks different than anybody else's. But if several people have viral sequences that are similar, this can indicate that the virus is being transmitted more quickly than usual. These molecular data can be used to help inform public health activities. Public health agencies can analyze the sequences or molecular data to find groups of infections that are similar. CDC is mainly looking for clusters where there are 5 or more HIV transmissions in the past 12 months with no more than a 0.5% genetic variation between the viruses. In fact, we found that HIV is spreading 10 times faster in these networks compared to the average. Health departments can reach out to members of these networks in collaboration with community partners to provide the services needed, as well as understand barriers to care and prevention and develop approaches to overcome the barriers. So when we think about, in many ways, cluster detection and response activities are a strategy that feeds into other HIV prevention strategy. So when CDC looked at the first 60 clusters that were identified using molecular data, except for a few instances, the health departments were really not aware. Even for those few health departments that were aware that HIV was on the rise, they were not aware of the large size of the clusters or that increases seen in some different, or increases that were seen in some different geographic areas were connected. So when used with traditional public health tools, cluster detection activities can shine a light on populations and networks that are not being effectively reached by existing prevention activities. I like to think of it as an iceberg. A cluster is typically the tip of the iceberg. For example, cluster response might identify those who are diagnosed with HIV but out of care, those who have HIV but not diagnosed, and individuals that are at risk for acquiring HIV. Through these activities, we can link people to care if they are living with HIV or appropriate prevention services if they are at risk for HIV. In many ways, we always use surveillance data to guide our prevention efforts. Cluster detection and response is an acceleration of this data-driven approach that uses data in real time. This allows us to effectively focus limited prevention resources. So what I want to do now is really describe for you some examples of how identifying networks of rapid transmission using molecular data can strengthen our prevention efforts. For example, in 2017, Texas identified a large group of Latino gay and bisexual men in San Antonio with similar HIV strains. 24 men were initially identified as having similar strains of HIV. After CDC and the health department followed up, another 87 people were identified as being sexual or needle-sharing partners. Additional information gathered by the health department revealed that HIV testing wasn't always being conducted according to guidelines, and as a result, providers had missed opportunities to diagnose people at the stage of acute infection, resulting in delayed treatment. The investigation also highlighted a lack of access to PrEP for many who could have benefited from it. In response, the health department sent an alert to providers clarifying the guidelines for HIV diagnostic testing and acute infection and increasing providers' awareness of PrEP. In addition, health department funds were redirected to increase access to PrEP in specific areas of the cities. Responding to this situation brought together a new coalition of community members, providers, and public health staff in San Antonio. As a result, the coalition provided both political and community support that enabled San Antonio to sign on as a fast-track city with commitments from the mayor and the city council to work together to reduce stigma, improve care, and eliminate new cases of HIV. So these are things that health departments are already doing, making sure that people are educated about HIV and that prevention services are reaching the right population. This is an example of cluster detection leading to an opportunity to detect gaps in services and how the health department can redirect efforts to make sure that the services are reaching the populations that need them the most. So now I want to turn to addressing some communities' concerns and et cetera. We know that public trust is the foundation of our work. Public health agencies collect data and uses it to improve health. This offers a benefit to the public. This is how we know what we know about HIV in the U.S. It helps us to build programs to serve groups of people living with or at risk for HIV. identify health inequities and work to end it, and reach out to people who need additional supportive services. However, in this work, we must protect the data and ensure it is used for the health of individuals and the community. State and local health departments have a duty to protect the public health, And as part of that responsibility, they collect information when people are diagnosed with reportable illnesses, including HIV. These agencies have many protections in place to safeguard people's information. Some of these policies and procedures are required by CDC, and health departments have additional protections in place specific to their area and circumstances. Whether at CDC or your local health department, we keep all HIV public health information on secure data systems and only allow people to access information if they need it to do their jobs. We also require people to access the data we also require people who access the data to complete a data security training annually and to sign a binding confidentiality agreement. Personally identified information such as name, address, or phone number is not sent to CDC. We aim to use these data to help improve people's health. We've also been talking with a variety of people about this work and how we do it, and there has been a number of questions and concerns raised, including the extent to which public health activities will be conducted in ways that are culturally sensitive and non-coercive. That's certainly our goal. People have also raised questions about the level of protection for public health data. People need to feel sure that these data are protected from improper use. Data held by CDC are maintained securely according to strict guidelines and regulation, and we require that health departments maintain their HIV data securely as well. And we also have processes in place to monitor what's happening in the health department. Since HIV is a reportable condition and states must comply with complete laboratory reporting laws, we are really emphasizing that states ensure their data is protected. We're emphasizing also that health department needs to access their existing need to really assess their existing data protections to ensure they are adequate to protect against non-public health purposes and to assess whether their jurisdiction have criminal exposure laws. Many of these laws were passed long before we had this tool and evidence on ways to decrease risk of transmission, and they are now outdated, and we are working with jurisdictions to help them update these laws appropriately. We have also heard concerns that molecular analysis could tell who infected whom and be used in criminal proceedings. Currently, our molecular technology and the analyses that we conduct cannot tell who infected whom. We can only tell that the viruses are closely related. We don't know if there are people missing from the data and who could have been a link between people. We do not use molecular data to determine direction. We use these data to detect growing networks of where rapid HIV transmission is occurring so we can intervene to stop transmission. I want to emphasize that community engagement is critical. We always recommend that health departments engage their communities around the work that they are doing because we know that we are all working towards the same goal and that community members have a lot to offer. CDC has engaged various community members at conferences and through a series of webinars. We plan to continue engagement around cluster detection and response activities. Given that cluster detection and response is new and there's still a lot to be worked out, engaging community is particularly important. Community engagement aims to inform community of the program, engage stakeholders, and hear their priorities and ideas. This offers the opportunity of building support and also of identifying ways that we can partner with community to achieve our common goal. It also honors past processes and agreements with communities. I want to close by saying that we can end HIV. We are at an exciting time in HIV treatment and prevention. We can detect infection and networks of infection earlier than ever, saving lives and preventing transmission. CDC is committed to using both traditional public health tools and the new tools in our toolbox to end HIV. We are also committed to responsible use of the data, to hearing your concerns and working with community to address them. and to using the data we have to more effectively reach and serve more people with or at risk for HIV. Thank you. And I guess the last slide is basically to indicate that I have no disclosures.
Okay, thank you so much, Dr. McCray. Really interesting presentation, and I know it's really appreciated how you've incorporated some of the community concerns into your presentation, especially this question of direction of transmission, issues with criminalization, and really how this technology is being used from the CDC's perspective to add more to the public health outreach. So thanks for starting this conversation today. I don't see any questions for you so far, so just a reminder to folks, you can feel free to use that chat box. And while folks are thinking about questions, we can move to the next presentation. So I will turn it over to Naina Khanna.
Great. Thank you so much, Brian, and thank you to Dr. McCray for an excellent overview of what's going on with molecular HIV surveillance and addressing some of the concerns. So I'm just going to try to dive in a little more deeply to what we've been hearing from people living with HIV advocates about some of the concerns, human rights implications in particular for this public health strategy. So again, my name is Naina Khanna. I'm Executive Director of Positive Women's Network USA, and if you're not familiar with our work, we are a national membership body of women and folks of trans experience living with HIV. We've been around since 2008, and what we do is really build leadership among communities most impacted by the epidemic. We mobilize and organize on policy issues at the local, state, and federal level, and of course, we work to ensure that policies around relating to people living with HIV are human rights informed and gender responsive. And so, as folks may know, and as Dr. McCray sort of mentioned, this idea of using surveillance data to drive resources and to address the epidemic in the United States is not new. It was sort of a key part also of the National HIV/AIDS strategy, which was developed and rolled out under President Obama. And a key part of the first National HIV/AIDS strategy, which was released in July of 2010, focused on expanding the use of HIV surveillance data under the Data to Care system to improve engagement and care. And so there were a number of jurisdictions that have been performing molecular HIV surveillance, since that strategy was released and over the last several years. And in fact, molecular surveillance has been used in some jurisdictions for as long as about 14 or 15 years. It's been used in New York City in some instances. In Washington State, it's been used for quite a while, and so this is not actually a new tool. So I guess the question really is, why are we talking about this now, right? If molecular HIV surveillance is not new. Well, we're talking about it now for a number of reasons. One is the current occupant of the White House did make a statement in the State of the Union recently, an administration-level commitment to ending HIV transmissions by 2030. This strategy that was rolled out by the administration, had a lot of input from different federal agencies, and of course, HHS also rolled out a plan to accompany this. So, in the Ending the HIV Epidemic Plan, which was put forth by Alex Azar, who's the Secretary of HHS, it's very clear in this plan that's come from the Trump administration that there is an explicit focus on data and surveillance. And so there are three, sort of major areas of action that are identified in Alex Azar's piece on this, and one of them is using data. And so it's very clear that molecular HIV surveillance is sort of a key aspect of this plan. And if you look sort of further into the plan, you can see that they're talking about responding rapidly, detecting and responding to growing HIV clusters, preventing new infections, using this epidemiological technique to, to kind of intervene quickly and responsively. So there's clearly an increased level of commitment to utilizing molecular HIV surveillance that we're seeing from the administration and federal agencies, and a lot of dollars and resources going into implementing it. And in fact, there's been like an expanded rollout basically since January 2018, which I will talk about in a minute. But first, I just wanted to give folks a chance to read this quote and see if anybody has any ideas on who made this statement. So you can put your guesses in the chat box. I'll read the quote just for anybody who may not be dialed in on the computer or can't see this. The quote says, "It is time to reject the temptation of denial of the HIV/AIDS crisis, to reject false prophets who preach the quick fix strategies of condoms and free needles, to reject those who preach prejudice, and to reject those who try to replace God as judge. The time has come for the Christian community, members and leaders alike, to confront the epidemic." So any guesses on who made this statement? Okay, I see a couple in here. Jesse Helms, Mike Pence, great guesses. Any others? Okay, so in fact, it was Dr. Robert Redfield, who is now the director of the Centers for Disease Control and Prevention as of last year. So Dr. Redfield was appointed by Trump to be in this role, and has a very interesting history of relationships to people living with HIV and the human rights of people living with HIV, including putting forth a mandatory testing strategy, proposing quarantine, and other types of things. And so, this is a link to an article from Foreign Policy where you can read a little bit more about Dr. Redfield's history. So there are some concerns that while we know that we have a lot of wonderful allies and career folks in these federal agencies, such as CDC, like Dr. McCray, who have been committed to doing this work in an ethical way that upholds human rights and dignity for the most vulnerable communities for a long time, it's not clear that at some of the highest levels of leadership, this administration shares that commitment. And so there are some real concerns about that. On the topic of community engagement, again, it's really great that this was brought up because it is such an important issue. And so back before molecular HIV surveillance was really expanded, and I'll talk about that in just a minute, a consultation was held in 2017 to discuss ethical, legal, and human rights concerns. And there's a report from that. Consultation that includes a list of participants who attended, and it was 41 experts from multiple fields that attended that consultation. So this number you're seeing here on the right of your screen, 0, is the number of people living that were invited to participate in this consultation, that knew about it, and that attended the consultation on ethical, legal, and human rights concerns about having our molecular HIV data utilized in this type of way by the Centers for Disease Control and Prevention and others. And so, I think on the topic of community engagement, absolutely it is important, and it's troubling that even some members of the HIV community that have been involved in sort of leading on this issue, advocating for this issue, thinking about how this data could be utilized, did not reach out to the vast number of people living with HIV networks representing vulnerable communities in the U.S. And so what we do know is that as of January 1st, 2018, the CDC is funding all health departments now to support reporting and monitoring of the results of this phylogenetic analysis. So I showed you that map earlier of what molecular HIV surveillance kind of looked like previously. Now it is all health departments and all jurisdictions that are engaged in this monitoring. And so that has been happening as of January 1st of last year. And it was done through kind of a large funding opportunity announcement where jurisdictions basically had to respond with a detailed description of the types of surveillance, molecular HIV surveillance activities and intervention in accordance with them that they were going to be taking on in order to receive the funding. So, many of the U.S. people living with HIV networks did not know that this was happening. And so we started to become aware of it in early 2018. And in June of last year, there was a meeting with CDC and NIH to talk about molecular HIV surveillance and raise some of the concerns. And these are just a couple of actual questions and answers that came up at that consultation. So we explicitly asked questions like, what steps is CDC taking to protect this data from other federal agencies, for example, the Department of Homeland Security or ICE? The response was that the data is protected, but there are no specific barriers between the federal agencies. They're still looking for more protection. We also asked whether there was a minimum standard of data protection that states or jurisdictions had to meet in order to receive the funding for this PS 1802, which was the funding announcement. And we're told that all states already have guidance as a condition of their funding. There are no special considerations for molecular HIV surveillance. So I'm going to talk a little bit later about a report that came out looking at different states. So on this subject of directionality, so the question that directionality is really trying to answer is, do we know, does molecular HIV surveillance tell us who the infection came from and who it was acquired by, right? And so what you can see here is that no, basically where the science stands right now, it does not show us, it both does not show us, who the HIV came from and who acquired it, and also does not show us that a transmission happened directly between two people. So specifically, if two people are in the same cluster, it can be the case that the virus went from one to the other in either direction. It can also be that the virus went from one to the other, but there was somebody in between. It can also be that both people acquired the virus from the same other person, right? So those are just a few examples of the relationship between this. But the problem is that part of the problem here is that it's not just about science. This is also about how these questions are taken up in places like the law and in courtrooms and by juries. And so there are lots of concerns that, this hasn't always been interpreted accurately. Also, there is some dissent. It is not clear that all scientists are on the same page about whether directionality can be inferred from molecular HIV surveillance. So, from one of the people who's been kind of leading this work, one of the scientists, Dr. Leitner, who's at the Los Alamos Laboratory, which, by the way, is where our data is stored, one of the places where our data is stored. And if you don't know the history of Los Alamos, it's also where nuclear testing has been done. So, according to Dr. Leitner, phylogenetic analyses usually are coming with other types of data that could make it possible, in some cases, to identify the source and/or recipient of a transmission. So this is contested, right? The level of where the science is contested. It's also likely that at some point it will be possible, given advances in science, to determine directionality of transmission. And so while most scientists believe that the science has not yet advanced to infer directionality, even if that's true, it could just be a matter of time, right? And so, and we know from lots of evidence that judges and juries often don't understand the science enough to make informed decisions on matters of life and death for people living with HIV, and matters of our basic freedom and our basic dignity, right? So in criminalization cases, for example, and we know that over 30 states and U.S. territories currently have some kind of law criminalizing HIV on the books, and that there have been prosecutions and convictions of people living with HIV for alleged exposure, transmission, non-disclosure, even in states where there are not HIV criminalization laws. This is a serious problem. We actually have an epidemic of HIV criminalization in the U.S. that's among the worst in the world. And so it's not clear that given HIV stigma, misinformation, that people making decisions about what happens in a particular prosecution are well informed enough to understand where the science is. And we really can't expect them to be, right? This is very technical information that many of us don't adequately understand. So I think many of us are familiar with the case of Michael Johnson, a young Black gay man in Missouri, who was sentenced to 30 years in prison for allegedly not disclosing his HIV-positive status. And his sentence was reduced to 10 years, but this was a case where racism and homophobia played a tremendous role in the trial, in the media coverage, and in the sentencing. And science played a tiny role, actually. If you look at and I've read the court transcript as well as, followed a lot of all of the media coverage, actually, of this case. And if you read the court transcript and the media coverage, you can see that throughout the trial, there were lots of misrepresentations of the science. HIV was characterized as a death sentence, as a deadly weapon, basically. Sequence data was not even admitted as evidence. There was a medical doctor testifying who was kind of like not that well prepared for the testifying on behalf of the defense. And, that medical doctor pretty much ran out of the room crying, literally, rather than adequately representing Michael Johnson. And so both transmission and directionality were presumed in this case, even without the science. And so I think it's important to note that just sort of the specter of possibility that there is science that can show that whether a transmission happened or an acquisition happened from one person to another can be enough to convict. And it has been used, actually, in some cases. And so these are a couple of cases where phylogenetic data was used to convict folks living with HIV in criminal prosecutions. And in one of these, they literally got the sequence data from the Los Alamos lab, because guess what? It's actually publicly available. The identified sequence data is actually available. This is the link where you can go and look up on Los Alamos, and you see there's a link to a sequence database on here. So this information is available. It can be used for research, and there's variation in the types of protections that are required in different states in order to conduct this type of research. So we would think that there are laws in place to protect us, right, for all of this. And the answer is, well, sort of. I mean, there are, of course, some laws to protect people living with HIV, but they're not consistent, and they could be stronger. And so there's a report that came out from NASDAD, the National Association of State and Territorial AIDS Directors, last year, looking at the landscape of HIV data privacy and confidentiality. in the context of molecular HIV surveillance. And in the interest of time, I won't go into this in a lot of detail, but I do want to invite you to check out this report. It's a brief paper, maybe 8 to 10 pages long, definitely worth reading. This is the link for it here. And so they looked at 10 different states that were chosen to reflect both the geographic diversity as well as variation in the types of different health department data sharing activities. And so this is a very brief summary of what they found. Number one, they found that there was broad authority in statutes for health departments to disclose personally identifiable HIV data without consent if it was being used for surveillance, investigation, or control of communicable disease, for treatment, payment, research, or healthcare operations, or, quote, justifiable public health needs. They also found that data sharing activities really vary depending on the jurisdiction, and that states also vary on whether a subpoena or a court order is required for the production of HIV data from a health department. And this is important because something that we have found is that often people working in health departments are not necessarily informed about what data they're legally required to disclose and how in the case of a criminal investigation or some kind of civil investigation. And so there have been instances where public health officials didn't know whether they had to respond to a subpoena or a court order. And we have anecdotally heard cases of from surveillance officers at health departments who told us that they were not informed about their own rights to say no to this type of data request. Also, they found that the legal authority to share the data for research purposes varied. So some states required de-identified data, others would allow identifiable data, but the publication of the research had to include only de-identified data, and other states did not have statutes addressing this at all. So I really recommend taking a look at that report. This is just a little sample of some of what they found in the different states. So, for example, in Illinois, if there's a court order or a subpoena, information and records related to HIV can be shared for prosecution under the Illinois HIV criminal transmission statute. So there's, again, there's variation here and something to look at. Of course, there are lots of reasons to be concerned about populations that are especially vulnerable. And what we see when we look at many of the clusters that are being, quote, tracked, and I always use air quotes when I say clusters because when we talk about clusters, we're talking about people, right? So people living with HIV are what comprise these clusters. So there's a recent cluster that is being tracked in North Seattle among people who use drugs and homeless folks. This is written about in a newspaper just as recently as last week. Women of trans experience, the case that Dr. McCray mentioned in San Antonio, which is actually a lot of Latinx men who have sex with men are in that cluster. These are all communities that this administration has also chosen to target and go after and strip of their rights. And so there's a tremendous amount of concern about each of these communities independently of HIV status and molecular HIV surveillance, and the idea that surveillance is being used in this way and could be used in other types of ways to advance goals of the administration's, racist, bigoted, prejudiced, and xenophobic agenda is certainly concerning. And so, we literally have an administration that is directly coming after some of these communities, and even in places that are, sanctuary locations, it's not clear that there's not a level of collaboration between ICE and law enforcement, and it's quite unclear what the relationship to public health could possibly be, and especially if we're talking about a place like the like prisons and jails or a Bureau of Prisons in a state, what the relationship could be with agencies like ICE for people living with HIV. So just to wrap up a little bit, what can we do? Well, the U.S. People Living with HIV Caucus and others have basically called for an immediate moratorium on molecular HIV surveillance while these data security concerns are addressed, and under any administration that is directly targeting the communities most vulnerable to HIV in the first place. At a local level, of course, you can meet with your health department to find out what they're doing, identify opportunities to increase protections of this data, and we can demand better community engagement, which includes, not just inviting folks to meetings, but directly resourcing people living with HIV and other vulnerable communities that are going to be impacted by this rollout of surveillance activities to be there. So making sure that that vulnerable folks from the communities that are directly being targeted in these clusters are able to attend those meetings, are compensated to be there, et cetera. You can do research on the data privacy landscape, data sharing agreements in your own state. And then cultural humility has to be a big piece of this, because for many years we have heard concerns about disease intervention specialists, DIS officers, and the ways that they have approached even linkage back to care types of activities. And violations of privacy that have resulted. And so surveillance, both surveillance leadership and those who are on the front line should be trained in concerns relating to people living with HIV, concerns relating to vulnerable communities, kind of like know your rights information and cultural humility. And this point about surveillance leadership is also really important. I personally sat in a room with somebody at a health department that has been doing some really incredible HIV surveillance work for a very long time, who admitted that they had never actually met a person living with HIV until a couple of years ago. And they had been involved and working in the field for, a decade, 2 decades. So it's important to understand that some of the folks who are making decisions because they're excited about a new technology, opportunities to intervene in an epidemic, which of course we all support and want to see happen, don't necessarily have a grounded understanding of the real life consequences of what they're proposing. And so making sure that surveillance leadership, actually receives some interaction and training from people living with HIV is important. Of course, getting involved in the HIV decriminalization movement and in advocacy on molecular HIV surveillance. And so there are some resources here. And I just wanted to leave you all with a few websites where you can get some more information. And I will stop now for any questions. Thank you.
Thank you so much, Naina. And I know we're running a little bit out of time, but I wanted to be sure to take this moment to thank you and everybody at Positive Women's Network for really standing up for communities, for people who are vulnerable, and holding the stewards of public health and of research accountable to these communities. So thank you so much for your brilliance today on this webinar. Really appreciate it. And thanks, of course, to both speakers as well, Eugene and Naina. Clearly, this webinar series has garnered a lot of interest and a lot of response, so it's something that was clearly needed, and I really appreciate both of you and your willingness to come and present and do some of this education and outreach. So with that, I see we have a few questions, and we have a few minutes to get to them, and I see more are coming in. So let's just go ahead and get right into them. It looks like most of them so far are going to be directed at Eugene and CDC. And this one is coming from Jacob, who is bringing up something that Naina pointed out, I'll just read the question. It says, you said that the CDC has protections in place to ensure that this data is not used in prosecutions. However, in some states, and Missouri is in parentheses, the Department of Health is required to turn over information, files, data for prosecution, and the state then uses this information to prove that a person living with HIV had knowledge of their status, aren't these in direct conflict? What are the additional protections the CDC is talking about? So Eugene, do you have a response to that question?
My phone was on mute. So as I mentioned in my presentation, we've taken a number of steps to help protect data at the state level. And as a condition of HIV prevention funding, state and city health department must comply with strict CDC standards of data security, encryption of electronic data, physical security, limited access, training, and penalties if procedures aren't followed. And I can go into a list of what those are. But with all that said, there are state level policies and laws and policies in some place that the jurisdictions have to comply with, and I don't know the details about Missouri, and all of what's being said may be true, but we cannot basically force the state to violate their laws and policies. But with that said, I think the goal of all states and many of the states is to really do their best to protect the data. And even when there are laws in place, they really work very closely with their legal counsel and others to make sure they are being as responsible as possible without committing a crime themselves.
Okay, thanks for that response. And Jacob, just I think you can see that Eugene put the statute in there for your reference as well, 191.677, requiring the Department of Health in Missouri to participate in prosecution. So that's just for your reference. A few more questions that I want to try to get through. So this question from Julie says, doesn't molecular cluster analysis and surveillance assume that a local HIV testing system is using fourth generation HIV testing and adequately detecting acute HIV? What if our community has very little access to fourth gen and acute testing?
Yeah, this is fourth gen testing is not required at all because what the phylogenetic testing is doing is testing doing genetic sequencing on the virus itself, and it doesn't matter it doesn't matter the type of test that's being used for detection of antigen antibody.
Okay, thank you.
And
Harry,
just for people on the phone, I just wanted to mention, just for folks on the phone, fourth gen is what is referred to as a test that tests both for antigens to the virus as well as antibodies. So it's testing for sort of genetic materials to the virus as well as antibodies.
Great, thank you for that. Harry is asking if Dr. McCray could shed any light on the success of MHS in terms of HIV prevention.
Yeah, I think the one example that I gave, and there are a number of successes, but the one example that I gave in the presentation that I think I would want you to refer you to is the San Antonio example, where they actually have had relatively good success in really in stopping the growth of their of the cluster. So many in the communities have benefited as a result. So we aren't able to tell exactly how many infections were averted, but the fact that the cluster stopped growing and we stopped seeing new infection really meant that we prevented infections and improved the health of that network of individuals. So the other thing is that we have looked at least 60 clusters that were identified using these methods, and the health departments in many cases were not aware that rapid acquisition was happening except in a few cases. And even for those few health departments that were aware that HIV was on the rise in their area of state, they had not realized how large it was, all that increases were being seen in different areas, increases that were being seen in different areas of the state were connected. So this information was used together with more traditional public health tools to make sure people got tested, to get them diagnosed and into care as early as possible. And in doing this work, health departments were able to diagnose people early, and sometimes during the process of seroconversion. Yeah, and then although it was really hard to really, as I said, to identify who didn't get HIV because of our efforts, we have seen that as health department has focused their efforts on rapidly growing cluster, the growth has either slowed down significantly or stopped. So this is clearly effective in areas where they're able to use the data in a responsible way.
Okay, great. Well, I know that we are at time. We do have 2 questions left, and I just got a note that Dr. McCray has to take off. So what I will do is I'll send those questions to Dr. McCray and see if we can get some responses after the webinar. But just wanted to remind folks that there's one more part in this webinar series coming up, and I just dropped in the link for registration into the chat box. So we hope to see you all on Wednesday, May 15th at 1 p.m. Pacific. So again, thank you so much to both Dr. McCray and to Naina Khanna for your presentations today. It's really appreciated, and we hope to see you all soon. Thank you.
Thank you so much.